Good evening, everybody. My name is Steve Willett, and I'm your chair for this evening. I'm a GP and clinical lead for substance misuse in Nottingham, and I'm chairing this webinar on behalf of SMMGP. It's been made possible by an unrestricted grant from Althea, which we're very grateful for. Just before we get going, I'd like to advertise the SMMGP Premium membership. If you're enjoying this webinar and others that we've run, then there are 15 hours of online CPD per year, mixture of webinars, research, from as little as £50 a year. There's an interesting webinar coming up. There'll be Dr. Owen Bowden-Jones talking about chemsex, the key issues. That's taking drugs specifically to enhance sex, usually by men who have sex with men. And that will be on the 3rd of December. As part of this series that we're doing, the fourth one in the series will be Professor David Nutt doing a webinar on medical cannabis and drug policy in the UK, a bit of a sticking point there. And that will be on the 4th of February. Now, we are still in our sort of very early days here, but we're delighted to have a fantastic resource tonight. You can see there that that's Professor Nick Lintzeris. Welcome to you, Nick. And if I can just tell you that that he is the Director of Drug and Alcohol Services in Southeast Sydney. Look, it's 6 o'clock in the morning for him there, so big round of applause, please. And he's not only a professor in addiction, he does a lot of work as a clinician and researcher in opioid and cannabis use disorders. He's something of a legend, I can tell you, in the buprenorphine field. But that's not our subject tonight. We are going to be talking in our third of our series, Medical Cannabis. Does it have a role in the treatment of substance use disorders? So we'll get going in a minute. What's going to happen is that Nick will be talking for 20-30 minutes. There'll be plenty of time for Q&A. So please get your question in, and I'll do my best to put all of those to Nick. Obviously, depending on how many questions there are, we may not get round to yours, but I'll do my best. You can put comments in the chat box too that I'll see and try and take note of. But first, we've got a question for you. Okay, if we can have the first poll. Just to give us and Nick some idea of who he's talking to, if you could click now on what is your role. Not the most difficult question of your day, but if you can answer that as quickly as you can so that we know you're there, that would be great. Okay, let's have those answers. There we are. We can see people are indeed there. So mixture, but in fact it's almost as many others. Be interesting to know who they are. I'm sure some psychiatrists in there, and no doubt a big hodgepodge. But more importantly, the next question, please, Kate. So this is to see where you're at with the subject of tonight. So, do you think there is a role for medical cannabis in the drug and alcohol treatment sector, particularly in those disorders? Okay, answer quick as you can, and we'll see where you're at. What we're going to do is to sort of take this this poll again at the end to see whether we've had any change. Yes, please. Thank you. So, look, there is a lot of interest out there. The majority thinking, yes, there are, but maybe we can increase on that. So let's see. Now, that's enough from me. Thanks, Kate. Okay, so it's time now to welcome Nick on the subject of medical cannabis. What role does it have in the treatment of substance use disorders? Nick Lintzeris, thank you very much.
Good morning, or good evening, Stephen. It's lovely to be doing a webinar with the SMMGP, who I've had some dealings with now, I think for over 15, 16 years from the early days when you first started. Look, thank you. I'm going to be talking about medical cannabis and its role in the treatment of substance use disorders. This is a relatively newish area in our discussions around medical cannabis use. That historically there hasn't been a big focus either amongst research or clinical practice in this area. So this is an area that we're all learning a lot about as we progress. There's my backgrounds, that's all the various kinds of roles that I currently have. And so I'm a specialist addiction medicine physician. And I spend most of my days now actually just sitting in meetings, running services. I still do some clinical work. I just want to acknowledge the work of a Brit actually. David Alsop was a Manchurian who moved over to Australia and was really quite instrumental in setting up a lot of work around medical cannabis and substance use disorders, and some of the early research that was done, David led. I've got a number of disclosures there, mainly work with opioid pharmaceutical companies in the cannabinoid space. We wish we had more companies involved producing products, but have had some government funding for some of our cannabis work. Now, what I was going to do is a very quick overview of medical cannabis, what the compounds are, then look at how we might be using cannabinoids in the treatment of substance use disorders. And I'll be focusing a lot on cannabis use disorder, but then touch upon where we are with alcohol, opioids, and stimulants as well. And then I also want to introduce the concept of the development and management of cannabis use disorders in patients who are using medical cannabis for other conditions. And we'll talk a little bit about some of the research we've been doing there and some of the implications this may have upon the way we think about prescribing cannabinoids in the future. So very quickly, what I'll do is go through some of the pharmacology and then very quickly touch upon some of the experiences here about how we've regulated medical cannabis in Australia and maybe some reflections for you there in Britain. So I think many of you hopefully will be familiar with this concept of the endocannabinoid system. So we're starting to learn about this cannabinoid system. It's still very early days. We're aware that there are things such as the CB1 receptors and the CB2 receptors. The CB1 receptors largely affect a lot of the central nervous system and peripheral nervous system, and a lot of the functions such as memory, mood, executive function, analgesia, but also impact upon the gastrointestinal tract and a big impact upon the appetite, respiratory systems. The CB2 receptors tend to have much more to do with the immune system, and so seem to impact a lot on inflammation and neuropathic pain. Now, these systems operate because we have endogenous cannabinoids floating around in our both centrally and peripherally. And some of the better known ones are things such as anandamide and 2-AG. Also recognizing that there's a whole endogenous cannabinoid system of metabolic enzymes that either break down our cannabinoids, and in future, it may well be that in 10 years' time or in 20 years' time, that actually these become the targets of future therapeutics. Think about the serotonergic system and how, for example, we treat depression by things such as SSRIs, which actually block the metabolism of serotonin, for example. Well, that's where we may be in the future with manipulating some of the endogenous cannabinoid systems. So that's something that we will probably develop over the next decade or so, and there's a lot of interest in this area. But until then, one of the ways that we impact upon the cannabinoid system is by the use of exogenous cannabinoids. So that's where we consume cannabinoids, and there's two main pathways. They're either plant-based cannabinoids, so things that come from the cannabis plant, or synthetic cannabinoids. So you can make most of these cannabinoids in a test tube in the laboratory. So there's a big future there in terms of how that develops. Now, the main cannabinoid that most of you will be familiar with is THC. tetrahydrocannabinol, and it's a partial agonist at the CB1 receptor. Probably has a numerous range of other impacts upon the cannabinoid system, but the CB1 receptor is one of the main targets. So it can either come from the plant or can be made synthetically. Synthetic THC is also known as dronabinol. Now, THC is the cannabinoid which produces many of the psychoactive and physiological effects that we're familiar with cannabinoids, so with the cannabis plant. So all those psychoactive and physiological effects there. And you can see that there's a whole range of metabolic pathways as to how we end up with THC. And worth noting that THC actually results as it's a breakdown from THCA. So THCA is an acid form of THC, and that's actually, if you were to get a cannabis plant, a raw cannabis plant, there's a lot of THCA, not much THC. So one of the things you need to do is heat a cannabis plant to break down the acid into THC. THCA is not that psychoactive, very mild psychoactive effects. It's one of the same things that we also see with the CBD molecule there on the right. That likewise, in a raw cannabis plant, there's a lot of CBDA. You actually need to heat the cannabis plant to break that down to CBD, which becomes the more active compound. Now, THC has limited bioavailability actually. So if you were to inhale or smoke cannabis, you get about 20 to 30% bioavailability. Lower bioavailability if it's used through an oral mucosal or suppository, and quite low bioavailability when it's taken orally, only around 10% bioavailability. You can see there that you get different onset and duration of effects. So if you vaporize or smoke cannabis, very rapid onset of effects and duration up to about 90 minutes. If you consume it orally, it's a slower onset and a longer duration. This has got some valuable therapeutic aspects to it as well. So if you think of inhaling cannabis products, it's a little bit like using a short-acting immediate release profile of a medication, whereas an oral THC ends up being more like a slow release product. THC is metabolized in the liver, doesn't have much in the way of drug-drug interactions though at the hepatic level. The other main cannabinoid that you probably heard about is cannabidiol, that's CBD. Now, cannabidiol is non-psychoactive, so it doesn't produce intoxicating effects, no drug of abuse potential. But it's been discovered that CBD has a range of anticonvulsant, anxiolytic, and antipsychotic effects, and probably has a lot to do with analgesic effects of the cannabinoids as well. The dosing profile of CBD is highly variable. Now, in places like the US and Europe, there's been an expansion of these sort of over-the-counter CBD products that you can purchase from hemp stores and things like that. Now, these tend to be low dose, so in the range of 10, 20 milligrams a day. That's not really consistent with the kinds of doses of CBD that have been examined in clinical trials for a range of clinical indications. Usually when we prescribe CBD, it's a much higher dose, usually 400 or 800 milligrams a day. When we're treating things such as epilepsy, then we're using up to doses of 1200 milligrams a day. So you can see there's a huge difference there in the kinds of doses that are being considered. Now in Australia, CBD has been a Schedule 4 drug for a long time. My understanding is that with the registration of Epidiolex or CBD for pediatric epilepsy around the world, what we're seeing is CBD becoming registered as a medication. And so it's not being considered a Schedule 8 drug, it's a Schedule 4 drug. And you can see there's a range of clinical areas. There's a lot of interest in the use of CBD. The main one, though, in terms of indication is for pediatric epilepsy that's treatment resistant. Pharmacology, look, I won't go through all this, just to highlight, it's very poor bioavailability, so less than about 10% oral bioavailability. That's why there's a lot of interest in looking at non-oral routes for CBD. It is metabolized by the liver, and here we do see clinically relevant drug-drug interactions, and it's a CYP inhibitor, which means that if you're using it with other medications, if you think about some of the anti-convulsant medications, and this can have a huge impact on some of the plasma levels of those other drugs. You can see the pharmacodynamic effects there, as we described, not much in the way of psychoactive properties and very little abuse potential, no withdrawal when you stop it. We have to be really clear, though, that we actually don't really understand how CBD operates. It doesn't really have much direct binding to CB1 or CB2 receptor systems, so it's thought to modulate a lot of the other cannabinoid systems. We're still trying to figure out actually how CBD actually works, so it's still early days. Now, let me just highlight that in most parts of the world, what we've seen is an expansion of illicit cannabis use that patients start using for medical reasons. There's a lot of widespread support in the community, and my understanding not only in places like North America and Australia, but also in the UK, that when they go and survey people out in the community, often there's a lot of community support for medical cannabis, even though often actually people being surveyed don't actually necessarily have a good understanding of just what medical cannabis means. And some of the work we did in Australia and also in the in the US highlights that its cross-sectional studies suggest that it is not uncommon that a lot of people are starting to turn towards cannabis products, and particularly in the areas of chronic non-cancer pain, epilepsy, palliative care, and where in some of the surveys we're finding at about 10%, 15% of patients with those conditions admit to having tried cannabis to help them with their symptoms. And a recurring theme in this is that people turn to the cannabinoids generally when mainstream or conventional treatment is not satisfactory, either because of side effects or because patients feel that conventional treatments are not effective. The other key area that we're seeing a lot of this use is in the cancer therapies as well. There's been a widespread promotion on internet and things like that around the potential therapeutic roles of especially CBD for cancer. Now, when the systematic reviews have been done, it's fair to say that actually, other than areas such as spasticity and MS, we still are in the early days of establishing an evidence base. This is the now somewhat famous JAGA review by Whiting back in 2015. There's been a number of other sort of systematic reviews that have been done. The other area is chronic non-cancer pain, where there's been quite a lot of studies, often done around nabiximols, and now there's varying sort of governments in different parts of the world have sort of fallen on different sides of the fence as to whether or not there is a role for the cannabinoids in the treatment of chronic non-cancer pain. Countries such as the US, Canada, Australia, authorities have now sort of somewhat begrudgingly admitted that there is sufficient evidence to use the cannabinoids for chronic pain. I notice in the UK that there's less support from groups such as NICE in this area at this point in time. So in Australia, the Australian government, the TGA, issued our guidelines for medicinal cannabis. Largely, so whilst there was reluctance from a lot of medical groups, there's been such strong demand amongst consumer groups that the authorities have had to sort of somewhat begrudgingly recognise that there may be a role for cannabinoids for epilepsy, nausea and vomiting in chemo-induced conditions, MS, and in palliative care. So now there's a range of guidelines around the use of cannabinoids for those areas, and also this is spread into private practice. In Australia, we have either the only licensed product we have is nabiximols or Sativex, made by GW, a British company. I think, well, I believe many of you will be familiar with Sativex because it's licensed in the UK for MS also. It is a 1-to-1 THC to CBD oral mucosal spray, and it's a plant extract. Each spray has 2.7 milligrams of THC, and typically doses of 4 to 8 sprays a day when treating MS. And you can see the kinds of THC and CBD doses that you get there. In Australia, what we've seen is the expansion of unlicensed but regulated products. So these tend to be medical cannabis companies, either Canadian, Australian, Dutch companies such as Bedrocan, and these companies, they are yet to actually license these products as medicines, but they're available through special access schemes, and it's been the development of these high quality cannabinoid medicines. And so these are made to very high standards. They tend to be oral doses. We are not seeing the expansion much of inhaled or smoked products in Australia. They tend to be oral liquids and tablets, standardized composition, chemical free, so we know there's no pesticides or heavy metals or fungicides, and the composition is standardized from batch to batch. So you know, for example, if you're taking one of these tablets, that each time is going to be a 5 milligram THC dose, for example. So these are on the journey towards sort of licensed medicines. So in Australia, we have not gone down the North American experience of this expansion of edibles and low quality products where there's no quality control and a lot of variation from batch to batch. And we're not seeing the Canadian experience of widespread use of plant matter. So whilst almost all the cannabinoids are plant extracted that we are using in Australia, very little of it is plant matter direct that patients have to either vaporize or smoke. The experience in Australia is that we've had very slow uptake in the first 2 years of this program. It was in the matter of in the first year, I think we had about 50 approvals. In the second year, about 300 approvals. In the last year, we've gone from a matter of a few hundred to thousands. So we have around 10,000 approvals now. We've got about 1,000 approvals a month. And this has happened largely because of the introduction of private medical practice. So rather than expecting sort of government-based practice or public sector prescribers, which was very, very slow and controlled, it's really been the private system that has taken this up. Unfortunately, that does mean patients are having to pay for the medications, but it has freed up the system. And I think there might be some learnings for the UK system there as well. Now, when prescribing, I would highly recommend the European Journal of Internal Medicine back in 2018. There's a special issue around prescribed medical cannabis. You can see the reference there. A really excellent series of papers. One of the papers there was by McCullum and Russo, and they did a wonderful sort of overview on how to prescribe. You can see there the kinds of adverse events associated with cannabis-based medicines. And you can see there on the far left, you've got the most common types of side effects. Fortunately, they tend to be mild and transient. The less common or the rare conditions tend to be slightly more serious and severe in nature. You can see there some of the mental health problems. Fortunately, most of those settle down as soon as you just lower the dose or you stop prescribing, and most of those go away. We need to appreciate that a lot of patients won't tolerate medical cannabis when they try the products. About 20% of patients actually turn around and say, look, thanks, but no thanks. I don't like the side effects, especially with THC products. Now, interestingly, though, there's been almost no mention of dependence or withdrawal as side effects in all the clinical trials of prescribed medical cannabis. Now, think about when benzodiazepines and when opioids were first being introduced in medical practice, how the drug companies sort of, and even amongst the early research work that was done, very little discussion around the fact that there might be dependence or withdrawal to benzodiazepines in the 1980s or in the 1970s. It actually took the groundbreaking work of people like Malcolm Lader in the UK to identify withdrawal from benzos. And think about opioids, where until very recently, there's been almost no discussion around dependence to opioids or withdrawal from opioids. And that's really something that's only emerged in the last decade. So we need to be aware that with medical cannabis, whilst this is not something that's been discussed or comes up in the clinical trials, which tend to be time limited and low dose, I think this is an area that we need to be aware of, and I'll be coming back to this issue. Now, also just to recognise that there's a lot of potential harms with cannabis use. Most of the world's literature around the harms of cannabis come from illicit cannabis use, and we need to also sort of just be aware that a lot of that is about smoked and really high dose, high concentration THC. We don't necessarily see the same severity of these side effects when we're prescribing medical cannabis, where the doses tend to be lower dose and more oral products with sort of less peak plasma concentration. I think most of us will be familiar with some of the concerns around cognition. Most of that, though, is reversible, and there's not much evidence to suggest that there is any permanent cognitive impairments for adults using cannabis. Yes, there is a pretty sound evidence base that heavy cannabis use in adolescence can be associated with longer-term cognitive impairments and mental health problems, but there aren't a lot of clinical indications for high-dose THC in adolescence for medical cannabis, so I don't think this is really a significant issue for us when we're thinking about the role of medical cannabis. And you can see some of the physical effects there. This can have particular importance if we're thinking about prescribing to older patients, say with chronic pain, and some of the problems with hypertension, tachycardia, that can occur with cannabinoids. Okay, now let me get on with some of that's the background, medical cannabis and treating substance use disorders. Let's look at the area of cannabis use disorder or cannabis dependence. The first early work that started in this area was some of the synthetics. So the Americans started looking at the role of synthetic THC, such as dronabinol and nabilone. And then in Australia, we got interested in the use of nabiximols. So remember, that's Sativex, or the THC CBD 1-to-1. The first study we did in this area was looking at an inpatient cannabis withdrawal study. You can see there let me just check. Yep, we used an inpatient dosing study. This is a placebo study. Even though we didn't have large numbers, it was sufficient actually to demonstrate significant improvements in cannabis withdrawal symptoms and retention. So if we prescribed Sativex during the withdrawal, we found there was a significant reduction in cannabis withdrawal and more people finished the withdrawal. But what we found, though, is when we followed patients up 1 month later, that there was high rates of relapse to irregular cannabis use, and there was no significant difference between placebo and the Sativex arm. So that showed us that whilst it was effective in dampening cannabis withdrawal, that just managing withdrawal in its own right did not have a significant impact on longer-term cannabis use. And that's what we know in the addictions, isn't it? That, treating just alcohol withdrawal on its own or heroin withdrawal on its own doesn't have a significant long-term impact. The majority of people, most patients relapse if all you do is treat withdrawal. And that's what some of the other work has shown with dronabinol and nabilone as well. So that got us thinking, well, what if we were to use it as a longer-term treatment model? And we were thinking along the lines of something like a nicotine replacement model, where we might use medication, combine it with intensive counselling and case management. So we use the CBT model. And we ran a study which is a 12-week Sativex versus placebo head-to-head 1-to-1 RCT, where we used quite high doses of Sativex. So you can see there on the right panel, bottom right, we were using around 20 sprays a day. That's quite a lot of THC. That's around 50 milligrams on average of THC and 50 milligrams of CBD a day. You can see there was comparable retention in both arms. About 50% of patients completed the 12 weeks, which is not great retention rates if you think about of a lot of other medications. But when you run a clinical trial, that's actually the kind of retention rates you see with most medications in most clinical trials. Think about antidepressants. For treating depression, they're the kinds of retention rates you see. So what do we find in the results for cannabis outcomes? We found a significant reduction in the total number of days used. That's the top left panel. The top right panel, shows you that whilst we're giving the medication, there was a real sort of difference. That what we saw with the nabiximols arm, most patients either stopped using or dramatically reduced their cannabis use, either using 0 or 1 day a week on average. As you can see, the placebo arm, most people continue to use either 6 or 7 days a week. So you can see that the mean doesn't really do justice to that kind of difference in profiles. But what was really important is that when we followed these patients up 12 weeks after stopping treatment, that those differences were maintained. So patients did not necessarily go and relapse back to high rates of cannabis use. Now that was really important, because what that suggests to us is that we may well be able to use nabiximols or some form of cannabinoid agonist medication along the lines of a nicotine replacement model, rather than thinking of this as a long-term methadone maintenance program, where we have to keep patients on nabiximols for 1, 2, or 3 years. It may well be that we can use cannabinoids in combination with counselling and case management for those patients that are looking to get control over their cannabis dependence again. We also did a whole range of testing around cognition and so forth, and we found that there was no significant impairment in cognitive performance. This is really important because it means that our patients should be safe enough to be able to go and get on with their normal activities like work, operating machinery, driving, and so forth. But maybe we can talk about driving later if there's time. This raises the issue. So what is the role of cannabinoid agonist treatment? Well, I think first and foremost, we need to say we need to replicate these findings. This is the general trend that we've been seeing with nabiximols for cannabis use. There's been a couple of pilot studies now, and our RCT suggests this is going to be an effective treatment, but I think we do want some more studies to replicate this. I really want to highlight, this is not just about just medication. And I think now most of us would appreciate in treating addiction that you get better outcomes when you combine counselling with medication, not trying to do this with just medication alone or just counselling. So I think this idea that we can think about a stepped care model. Most patients who are dependent to cannabis can actually stop without treatment, and good luck to them, and maybe with just some support they can get through this. There are other people that can't stop cannabis use just on their own, and they probably need some support with some counselling. And data would tell us that about 20 to 30% of patients can stop cannabis use just with counselling. That tends to be people with sort of less severe cannabis dependence. But if for those patients though that can't stop just with talking therapies, that might be the role where we add medications such as nabiximols for those patients that can't seem to get away with just counselling alone. So thinking along the lines of a stepped care model. Not every cannabis user out there is going to need a prescription of nabiximols to stop to get control of their cannabis use. The other thing that we're really excited about is the potential role of cannabidiol for cannabis use disorder. So look, some of the animal work has been suggestive. Some early case studies indicated that you can dampen cannabis withdrawal, but we didn't really have any good longer-term findings. Some interesting sort of imaging work, MRI neuroimaging work suggesting that high-dose CBD may have some a role to play, but it's really just you can see I've highlighted there in red. Val Curran's team working I think at UCL and the University of Bath, they're yet to publish, but just announced at some conferences some really exciting work where they looked at CBD 400 milligrams or 800 milligrams in a sort of a pilot feasibility RCT compared to placebo. So it was a 3-arm RCT over 8 weeks of medication and counselling, and they found positive outcomes for reduced cannabis use in the CBD arms. So that's really exciting. Again, first RCT to demonstrate that with still smallish numbers, about 20 in each arm. But this again is suggestive that there may be a role for CBD. You can see there that it may well be that in a few years' time we start to be able to consider either nabiximols type approaches for those patients that want a bit of an agonist effect, or alternatively CBD for those patients that are looking to not have any psychoactive effects. Let me quickly walk through some of the other addictions, and I think it's fair to say that we are still very much in the early days of understanding how we might use medical cannabis to treat other types of addiction. So, look, all of us will be familiar with that. Patients on methadone and buprenorphine programs often will tell us that they use cannabis on the programs because it's a way of avoiding the use of other drugs such as alcohol or benzos or heroin. Some early pilot work suggesting that THC alleviates opiate withdrawal, some really good sort of laboratory studies. We don't have any clinical RCTs, any clinical trials demonstrating any enhanced opioid treatment outcomes through the use of THC-based products here. So that's something that will probably come in due course. There's a lot of interest around the world. Cannabinoids, opioid sparing, and it depends on what evidence you're looking at. If you're looking epidemiologically, so there's studies out there. So there's the famous one from the JAMA a couple of years ago that basically looked at from an epidemiological perspective that medical cannabis, those states that introduced medical cannabis had lower rates of opioid overdose. But again, difficult to interpret this. This is really high sort of level population data. Lots of studies where medical cannabis users with chronic pain, for example, will say that they started using their THC or their CBD products and they've been able to give up using their oxycodone or their morphine. So there's a lot of that kind of report. And we've looked at the clinical trials and the animal studies, a really comprehensive systematic review done by Susie Nielsen and colleagues. Really, the data just isn't there to support that sort of epidemiological work. So it's still early days, and I don't think we're there yet where we can confidently say that, you know, if we were using more cannabinoids, we would be able to markedly reduce opioid prescribing. So more work needs to be done, I think we need to say there. Then we've got the other areas, a lot of interest about the role of CBD for alcohol use disorder. The animal data is really exciting, but we're just really starting to use this now for first studies just starting up. We've got a trial where I think our first patient commences next week, where we're looking at CBD for alcohol withdrawal. Look, we're excited about CBD because think about what it does. It dampens anxiety, it helps with sleep, and it prevents seizures. So, and there's also some good data suggesting it might be anti-craving, all in animals. So if you think about all those properties, that makes for a really good withdrawal medication for alcohol, and then one that you could continue post-withdrawal as a relapse prevention medication. So we're excited, but it's still really early days, and I think we've got to wait for the clinical trials. Likewise, with the stimulants, both for cocaine and for amphetamines, the CBD data is exciting for anti-cravings, but we need some human data. It's still early days. So I think in summary, what we can say then, when we're treating cannabis use disorder, most of the evidence we have is for the use of cannabinoids for treating cannabis withdrawal and some emerging data for cannabis dependence. And we're all really excited about where we might be in a year or two with CBD for cannabis use. Then we've got the other drugs, and it's still really early days, encouraging. I think the addiction space is going to be greatly influenced by the role of the cannabinoid therapeutics. However, I think we also need to be just a little bit cautious. That in the addiction space, I think most of us who have been involved in this game now for a while will appreciate that you're not going to get great outcomes just with a medication alone. And in the same way that some patients will do okay just with medications, and some will do okay just with psychosocial, but I think the real benefits are going to be seen when we combine these two approaches. Now, I just want to touch upon this other issue very, very quickly.
Yeah, Nick, can I just say we've got 20 minutes left.
Okay.
If you can do this one really briefly, to leave time for questions, just maybe homing in on the main points. Great.
And the main points, look, simply because, again, you're not seeing a lot of this yet, but I think as it emerges, look, one of the things, I'll just touch upon this. But as we see more and more patients being prescribed medical cannabis for a range of chronic conditions, and most of the things we're interested in for the cannabinoids are chronic pain, some of the mental health disorders and so forth, so multiple sclerosis, long-term conditions. Now, think about what happened in medicine when we started using benzodiazepines and opioids. In the early days, we discounted that anyone could ever have problems of dependence or withdrawal from those medications. 10, 20 years later, we start to understand that those drugs like benzos, like opioids, that there's a minority of our patients, around 10 to 20%, that start who develop features of dependence to the medications. And that's what we're starting to see with some of the data around medical cannabis. And if we're interested in this caper of using medical cannabinoids, we also need to be prepared that there'll be a group of patients who start to develop dependence to the cannabis as medicines. So there's lots of epi data there, and some of the early survey work that we're seeing is around 10 to 20% of patients. Look, I'll just cut to the chase. Look at withdrawal. And we looked at these are people that were not prescribed cannabis, but they were using cannabis for therapeutic, for their own reasons. So these are illicit cannabis, but they were people who were responded to an online survey. They were saying they're using cannabis for medical reasons. Look at how common these were, the kinds of symptoms that patients reported when they stopped using cannabis, and 40-odd% met criteria for a cannabis withdrawal syndrome. And when we looked at rates of cannabis use disorder, about 40% met some criteria for cannabis use disorder on DSM-5, and about 17% met criteria for a moderate or severe cannabis use disorder, which is old term language for dependence. So I think this is, we need to appreciate that this is going to be an expected side effect of long-term medical cannabis use. And we need to think about what this means. And I think we should start thinking about a universal precaution framework at the very beginning of medical cannabis rollout. Let's be aware that this is going to be a potential risk about how we use medical cannabis. Let's start talking to our patients around this from the very beginning, and not sort of fall into the same mistakes that we fell into with the benzos and the opioids. Okay, so yeah, there's my summary slide. So I think as doctors working with patients with substance use problems, I think it's really important that we are active players in the discussions around how medical cannabis treatment systems emerge and roll out. I think one of the lessons is that in North America, a lot of the doctors and medical groups were sidelined from the introduction of medical cannabis, and it was left open to the politicians and to the lawyers. And so they really ended up with treatment systems that were not consistent with good health care. So in Australia, medical cannabis has been made much more of a medical sort of framework. I understand that's the role you're looking to go down in the UK. And that I also appreciate there's a lot of frustration early in the system. But I might stop there and throw it open back to you, Stephen.
Fantastic. Thank you very much indeed, Nick. That was not only a good overview of the whole use of medical cannabis and touching on some recreational cannabis use in the whole disorder issue, but actually it was a really good sort of more questions perhaps than answers on the use in substance use disorders, but you've certainly aroused plenty of interest. So let's go for some punchy questions. We've got quite a few coming in. Firstly, nicotine addiction. Obviously orally rather than the smoked variety, but what would you say about that?
So there's two aspects to that. So many of the patients are going to be coming in for treatment with cannabis use disorders and other use disorders, as you can, substance use, smoke nicotine, and when they look to stop their cannabis use, you also often have to treat the nicotine dependence. So your variety, your options there will be your nicotine replacement therapies, whether or not you want to use varenicline in the UK or not, So always bear in mind, if you're treating cannabis use disorder, think about treating nicotine dependence as well. But there's also a lot of interest. There's interest about and some interesting data about CBD for treating nicotine. Again, small case studies, case series, lots of animal data suggesting that there may be a role. But again, still very early days. We don't have the great clinical trials. And one of the outstanding questions with all CBD treatment is, what's the dose? So again, the kinds of over-the-counter CBD products that you can purchase in, online and in the hemp stores, they're often using sort of homeopathic doses of CBD, 10, 20 milligrams a day. Most of the data that we're seeing in the clinical trials, you're needing to use 200, 400, 600, 800 milligrams a day of CBD to get these kinds of clinical effects.
Yeah, okay, which they can't get over the counter in that dose. Thank you, Nick. Let's move on. What advice would you give on medical cannabis and driving? Does it have any dangers?
So this is one of the real complexities around the world. So let's look at a number of things. If you look at there's three ways of looking at the evidence around driving. You can either look at big crash studies, so epidemiological data coming out of who's had car crashes and what's the role of cannabinoids. In that, you can look at driving simulator studies, either in a computer or on the road. And you can also look at your cognitive performance data, just not where, give people THC and see what happens to them. Now, all that data from all those suggests that, yes, there is some impairment associated with cannabinoids, especially if you're using high potency, high concentration THC, like vaping, for example, or smoking in that hour or 2 hours after dose. However, like most psychoactive drugs, with chronic use, you become tolerant. So in the same way, benzos, opioids, antidepressants can all impact upon driving. Most of us are pretty familiar in counselling our patients, and with regular chronic use, you become tolerant. So cannabinoids are probably in the same range. So, the data suggests that cannabinoids are almost certainly safer than benzodiazepines, and probably in the same ballpark as opioids when we're thinking about impairment of driving. Not as dangerous as, say, alcohol. However, governments around the world are really struggling about how they regulate this and the kinds of advice that is coming out. And part of the problem in Australia, for example, where we have random drug driving, where they charge you for the presence of THC, not for impairment. So this is causing real problems in trying to, on the one hand, introduce cannabinoids as a medicine, and on the other hand, where you can see police are trying to prevent people doing illicit drug driving.
Yes, okay, thank you. Right, a lot of grateful listeners out there showing lots of interest, some frustration too, wanting, so one would come off their Valium if you can get the cannabis, and I think just venting frustration that it's taking so long in this country. Has this listener got a eureka moment that medical cannabis has no withdrawal and therefore risk of dependence? So,
we are yet to do the good studies of long-term low-dose THC use. Some work has been done with nabiximols, but none for patients with MS. And overall, small proportions of patients there were reporting what we consider withdrawal-like symptoms. But again, these are small studies or phase 4 post-marketing data, which is not very reliable. I think it is dangerous to assume that any psychoactive medication is not going to have discontinuation effects. So our patients find it difficult to stop, long-term opioids. They find it difficult to stop long-term benzos. Many find it difficult to stop long-term antipsychotics, long-term antidepressants. I think it is naive to think that there won't be discontinuation effects from long-term cannabis use as well. Now, whether or not that meets the full criteria of withdrawal, or whether or not it's just rebound symptoms or relapse symptoms. So, for example, if you're going to use THC to help you with sleep, for example, well, guess what happens when you stop using THC to help you sleep? You're probably going to have disrupted sleep architecture and you're not going to sleep well. Is that a full-blown withdrawal? Is it a relapse? Is it a rebound? That's the kind of, whatever it is, I think it is naive to think that you can use these kinds of drugs long-term and that some patients won't have problems when they stop. It means we should be tapering off. If you're going to stop, withdraw medical cannabis from a patient, let's do what we do with our other psychoactive medications and look to taper off over a number of weeks rather than suddenly stopping.
Yeah, look, that's really helpful. Okay, a little bit on the same vein, you were mentioning a lot of therapeutic medicines here. I've got a question. What do you think about the potential of CBD being used for patients who have a drug-induced psychosis and has now stopped using drugs, but has a lot of anxiety, nerves, and some paranoia?
A lot of interest in this, a lot of excitement about the role of really high doses of CBD, and they tend to be sort of 600, 800, 1,000 milligrams. So, we're talking industrial doses of CBD, but nevertheless, there's a couple of studies now where they've looked at CBD as an antipsychotic medication, and the data, again, not big, these aren't big numbers, 40, RCTs of 40, 50, 60 patients, so still early days, but the data there is suggestive that CBD does have an antipsychotic role, comparable with say amisulpride in some of the antipsychotic effects. But the other thing we see with CBD, again, also some of the anxiolytic, antipsychotic effects. So again, a lot of excitement in this space where it may well be, and especially for say some of the stimulant use disorders, we may have patients using amphetamines or cocaine, have a drug-induced psychosis. We can use the high-dose CBD to dampen not just the psychosis, then also to assist with the anxiety, the anti-craving, relapse prevention effects. So again, watch this space, but I think it's fair to say we need more data, because we're not talking about, just use 20 milligrams of CBD that you can just buy over the counter. It's not that kind of homeopathy kind of dose. We're talking about the kinds of doses, 400, 600, 800 milligrams a day, that most patients are going to really struggle to pay for if they're trying to buy that over the counter.
Yeah, no, good points. Okay, just broadening out a little bit from substance use disorders, your earlier bit has stimulated some other questions. Is there a use for medical cannabis in long-term pain, or what use is there, I suppose, is the question. What evidence?
Look,
do you think NICE will be reviewing and reversing their initial negative findings so far?
Look, it's an interesting one, because there's a number of groups around the world of, authoritative groups, the National Academy of Sciences, the JAMA review, a number of other sort of systematic reviews, the Australian TGA review. They've all looked, and the NICE, they've all looked at the same studies. I mean, it's the same RCTs. It's not as though they're looking at different RCTs. So they've all looked at the same studies, and they've sort of all come to slightly different interpretations of what the evidence suggests. So the National Academy of Sciences in the US said, yep, the data is good enough to tell us that it's effective, with moderate effect size, good enough to use for chronic non-cancer pain. In Australia, the same studies resulted in the TGA coming out and sort of being very guarded, saying, yeah, look, the evidence is there, but it's a really modest effect size. And most of our chronic pain specialists have all come out and said, look, it's really not, this isn't going to be a game changer. The effect size is really modest, you know, and it's only for a number of conditions like neuropathic pain. It's only if you're looking at things like nabiximols. So on the whole, we're not convinced by the evidence. We don't think there's a role for it. But then you talk to patients who are using it. And it's really difficult to listen to some of these patients who say, this completely changed my life. I was on all these medications. I was taking buckets of opioids and gabapentin and antidepressants, and my life was a mess. And then I started up, and, you know, I'm sure many of you have heard these stories. So we've got this disconnect between a lot of patient experience and patient-reported outcomes and what the clinical trials are telling us, and then what the authoritative sort of, you know, pain societies and colleges are saying. So I think this is a bit of a sort of what we call this evidence gap. I think what we can say is that the RCTs, you know, they point to there is a modest effect size, and what that generally means is that for many patients there's very little benefit. For a small group of patients there seems to be a big benefit, and then there's for many patients it helps a little bit. The things that we don't really understand, and I think this is where we're going to see in future, most of the clinical trials and RCTs went and excluded anyone who'd used cannabis, excluded most patients with comorbidities, such as other substance use disorders, such as depression, such as anxiety. They're the people that get excluded from RCTs. It may well be that what we're seeing with the cannabinoids, that it actually works really well for those people with chronic pain and the comorbidities of sleep problems, of depression, of mood, of anxiety, the so-called chemical copers. So it may well be that all the people that get excluded from your clinical trials because of all the comorbidities, that what we see with the cannabinoids is not so much the cannabinoids working as a good analgesic, but rather it just helps patients cope with the misery of chronic pain. And that's what a lot of patients are saying to us. When you do a BPI, the pain severity doesn't really shift much. You know, you ask them, and how bad's the pain? The pain's just as bad, but then what the patient will say is, yeah, but it doesn't bother me as much.
Yes. No, look, that's a powerful argument, and maybe we'd need to find the right way to capture that in a way that might persuade NICE. But I think we've time for just one last question. How about what contraindications there are using medical cannabis with other illicit drugs, including alcohol?
Look, I think we need to be cautious with all our patients about mixing drugs, especially if we're talking around things such as driving and so forth. I mean, when I'm saying that the data around THC and driving, that's THC alone. You mix your drugs, you mix your THC with alcohol or with benzos or any of those kinds of drug interactions, and I think we're all familiar with the cumulative additive effects of psychoactive impairment. So I think we're always going to have to be really, an area we're always going to have to be counselling our patients. And we also have to, appreciate that addiction is transferable from one drug to another. So that's another thing we always need to be cautious of. If you're, the kind of patient that's going to develop an opioid use disorder or an alcohol use disorder, it also makes you more likely to develop a cannabis use disorder to a prescribed medication as well.
Yeah, thank you, Nick. And one of the things that I took from your talk was the fact that, look, this isn't going to be a magic bullet. Yes, there can be some real value in having something that's regulated and safer, but where you can see exactly what you're getting, but it's only ever going to be really useful if it's combined with those psychosocial interventions and counselling. So that was fascinating. Thank you so much. Sadly, that is our time up. So very grateful to you at the beginning of your day there, getting up so early for us. We really appreciate it, and for all your knowledge that you've imparted. Thank you, Nick, and thank you, folks, for listening, tuning in. Don't forget the next one. It will be the 4th of February, but there are other things if you sign up for the premium membership. Goodbye and good night, everybody. Take care.